Data is just summaries of thousands of stories. Good afternoon, everyone. My name is Ned. This is Carly, Ciara, and Ben. And together we are UQ Masters of Business Psychology. And we're here to articulate our data story through the lens of dynamic consent and how an individual health consumer can interact with a web-based portal. So here in this little blue box, don't know why it's there, is we have a health consumer, or as we like to call, a data donor. Let's call him Harry. For the purpose of this solution, we have identified a health consumer as an individual who has been admitted to a Queensland public hospital. In the context of our challenge and our problem understanding, Harry's data goes through a journey to tell his story, to benefit himself, to benefit his family, his friends, and the wider community, to produce tangible and meaningful health outcomes. It specifically helps target interventions for specific populations, contribute to the sustainability of the healthcare, and coordinate co-production of research to help support the virtuous cycle, improving real-time care. And by naming consumers as data donors, we can also create an in-group identity and increase the sense of belonging. In understanding the nudge opportunities, we have depicted our hourglass framework. Yes, I know it's interesting, but just let us explain. So an hourglass can facilitate two-way communication through the data donor portal. It also allows transparency for data custodians to see the flow of information from our data donors to our researchers. We see the opportunities as motivating individuals to firstly engage with the portal, because if we don't have them on the portal, then their data is useless. Secondly, once we have them on the portal, it is about facilitating that dynamic consent through the hourglass. Carly's going to explain the first one.
So the first opportunity that we see is how do we even get health consumers onto the portal? What we're proposing is that on hospital admission forms, we include a question that introduces people to the data donor concept. You can see our suggestion up there. In this part of the process, what we're planning to do is frame it in a positive frame. So what we want to do is promote the individual's commitment to both themselves and their community. So pro-choice and pro-community. We're requesting from them a very small, easy commitment. We want to get their initial buy-in. We want to get a small investment of their time and their emotions. Not so hard. We're also giving them the choice of how they get contacted. And this ensures equity of access for all hospital admissions. Health and consumers are also going to be primed while they're in the hospital. There will be posters promoting data donors, and also hospital staff will be wearing badges that I am a data donor. But in order to take advantage of this priming effect, we need to ensure that the health consumers are contacted within a week of discharge. Important aspects of the message that we will be sending will focus on social identity to diffuse the responsibility. As psychologists, we had to include social identity theory. What we want to do in the message is we want to individually name them, we want to name the hospital that they attended, and we want to thank them for their contribution to the community. By creating this community and this small group identity, we limit the individual's belief that somebody else will participate and give their data. They'll also be reminded that they've already made the commitment that they wanted to get more information. The other important aspect is now we're going to use negative framing. We want to highlight what they're going to lose if they don't participate, because we all know that losses loom larger than gains. And finally, we will use the signature of a senior health authority to promote security and authority amongst the individuals.
Our second opportunity involves facilitating dynamic and informed consent between health consumers and researchers, and will utilise the principles of choice architecture to facilitate two layers of consent. The first layer will essentially involve linking health consumers' electronic medical records to this platform, and we've designed a choice architecture environment to support this process. We will build on health consumers' previous commitment in joining this data donor portal to help facilitate this consent process. In the same way that Apple has built an ecosystem to encourage and build on your commitment to continue buying their products, we will create an ecosystem of commitment. We will be pre-populating health data to reduce cognitive effort. Doing so ensures that consumers can spend that special devoted attention to verifying the accuracy of their data rather than wasting time inputting it into the portal. Humans love progress, and they especially love seeing their progress. And so we will appeal to the progress principle by visually indicating progress bars as they navigate through this process. When consumers are required to give their consent, we'll reduce their cognitive load through using simplified messages with 2 choice options, such as I consent or I don't consent. I want to emphasise that at the heart of this challenge involves ensuring consumers have adequate understanding of what they are consenting to. Does anyone here in the audience know how many decisions we make every single day? The answer is 48,000. That's a lot of decisions. To cope with this, we've developed 2 modes of thinking, our System 1 and our System 2, and we've essentially designed a choice architecture environment that takes advantage of these 2 modes when it matters most. You'll see that we've carefully selected when to flex between these 2 modes. So we'll take advantage of our System 1 when we notify consumers of a research opportunity, and we'll directly link them to the research information. This process will feel easy and automatic to the end user. Let's switch to System 2 now. We'll use the principles of smart disclosure to standardise the ways that participants read important information pertaining to the research. Standardising this information will enable them to effortlessly engage in the content. To facilitate enrolment, we'll have a participant select an enrolment button. Again, this feels easy and it appeals to our System 1. Our goal here is to then break the pattern and re-engage System 2. Rather than traditional methods such as I've read the risks and benefits, we'll adopt a different choice approach. For each statement that contains key information regarding the study, we'll phrase each question with an I understand. Framing the question in this way puts the onus back on the individual. And so by separating and breaking down each component, again, we'll engage System 2 to ensure users have a competent understanding of what they're consenting to. At the end of this, participants will ask to select whether they agree to participate. The whole point of this is that by thoughtfully engaging and flexing between these 2 systems, we avoid that icky feeling that sometimes we get at the end when we're overwhelmed with information and we just select I consent.
So we believe that our proposed solution is both practical and effective based on the theoretical backing, feasibility and implementation strategy that we're proposing. Firstly, for theoretical backing, we know that nudges, including the ones we've chosen, allow us to prompt individuals to make choices that are generally better for society, even though when they would not otherwise make the choice themselves, which we believe is possibly the case when it comes to personal data. We also know that the nudges that we've used are specifically aligned with the East framework that we all know and love. Secondly, when it comes to feasibility, the process we've outlined allows Queensland Health to utilise and build on the existing IEMR platform to reduce costs and allow for rapid rollout and testing in both urban and regional environments. Finally, when it comes to the implementation, initial requests to engage could be attached as a separate document to the admissions form to improve ease and reduce costs. However, as a standalone document could limit the authority and trust in the concept. We're not proposing that is the long-term solution. We also recognise that there's a need to invest in the platform, both on the user side and the back end, but we understand that could be quite costly in a sense, but we are trying to reduce this by leveraging the IEMR platform that I mentioned before, and when you consider the benefits, the costs are probably worth it. So in summary, our proposed hourglass framework utilises 2 distinct touchpoints. Firstly, when it comes to data donor engagement, we will utilise initial intention and reinforcement, incorporating priming, positive gain framing, and escalation of commitment, and also include a personalised message that utilises diffusion of responsibility, social identity theory, and negative loss framing. Secondly, we will facilitate dynamic consent using the data donor portal for existing data and leverage So like an hourglass, the grains of information fall from one side, the data donors, through a central point, the data donor portal, and emerge on the other side with the researchers. Like an hourglass, this information flow is reversible and transparent. However, regardless of the proposed solution, when talking about informed consent, we must remember that data are just summaries of 1,000 stories, and we need to ensure that we are treating them as such. Thank you very much.